or the Fernandez classification. So type 1 injury is being bending force acting on the distal. We are going to the shearing force. Barton fracture is a eponym, and this is the Fernandez classification in nutshell. Now type 2 is a shearing force where there is a fracture of the articular surface. The Bartons, then reverse Bartons, that's dorsal lip. The radial styloid fractures in a coronal plane or simple articular fractures. This classification has been demonstrated in these two articles nicely. John Rea Barton is an orthopedic surgeon from Philadelphia. In 1838, he demonstrated, or rather he described this injury very nicely. In fact, it's a very nice description of this injury pattern, which is demonstrated in this basic paper. And on this page 366, he has given a nice description that it's a coronal plane fracture of the articular surface of the distal radius, either on the volar or the dorsal side. In fact, he mentions it's a dorsal injury, which is very common, but in practice, we see volar Barton fractures quite predominantly or commonly than the dorsal. And precise one point he has mentioned is subluxation or luxation of the wrist. It is not a complete dislocation. It's a subluxation of the wrist. That differentiates the intra-articular injuries, the coronal plane intra-articular injuries from the radiocarpal dislocations, where the opposite cortex is intact in coronal plane injuries or the shearing forces. In radiocarpal dislocations, the opposite cortex is also injured and there is a ligament injury associated. Now, coming to these case examples in this shearing forces, on the left, this guy has a coronal plane volar injury. Similarly, on the right, this lady has a coronal plane injury of the volar articular surface. Coming to next, these two injuries are fairly common, whereas on the right, there is a subtle articular step and there is a central die punch also along with. And the last one is a severely comminuted intra-articular, but there was a significant dorsal lip and the carpus had a tendency to subluxate onto the dorsum. Going back to some basic stuff, this is a pictorial presentation in 11th edition of the Campbell. Whereas you understand the basic reduction maneuver in the dorsal intra-articular or the coronal plane fracture or shearing force, wherein you hyperextend or the dorsiflex the wrist to get the dorsal lip opposed to the radial shaft. And in a volar Barton fracture, you volar flex the wrist to get it opposed. But this is a baseline reduction maneuver to get the opposition of the articular surfaces. Now it has when the armamentarium, the fixation armamentarium was not so great, this was the maneuver which was being followed. But mind you, this close reduction needs very meticulous follow-up, very close follow-up. And in this, given this very unstable articular injuries, this reduction might not hold well for long, and you might have to come back and get the internal fixation done. And more or less in this era, we usually get this reduced in this maneuver and then plan for internal fixation with the given good quality implants what we have available. This Netter's pictorial presentation on the right, on the dorsum and the volar, these are the extrinsic ligaments of the wrist. The top diagram shows the volar ligaments, the radiolunate, the long and short radiolunate, and the radioscaphocapitate. These ligaments anchor the volar capsule and the volar articular surface. On the dorsum, in the middle picture, there is a dorsal intercarpal ligament and dorsal radiocarpal ligaments. Now, there is some strain in both these injuries, either volar or dorsal. There is strain on these ligaments, which remain intact in this particular injuries, although there is a opposing force on the. So in volar articular surface, the dorsal ligaments are at stretch, whereas in dorsal Barton fractures, the volar ligaments are at stretch. Whereas again, the point to reiterate is in a radiocarpal dislocation, these ligaments have higher tendency to get ruptured, and you need to address that. Volar plate fixation in vogue. Now the plate designs have improved, but primary contraindication of this volar plate fixation in these particular fracture patterns is radiocarpal fracture dislocation. Styloid avulsion where kind of B1, wherein you'll require a fragment-specific fixation of the radial styloid or a headless screw compressing that styloid to the main shaft. Dorsal shear patterns wherein there are ligamentous injuries. This Wooler plate screw designs might not get the hold onto the dorsal shearing forces, and you need to address it again fragment specific. Picture on the right is the old design, this standard Ailey's T plate. I'm sure seniors in the audience must have used this plate. I have no experience because of the evolving designs. This Wooler plate design is basically in this shear patterns, it's a buttress concept. So what this Wooler plate does is basically buttresses the sheared fragment and get the articular surface reduced. Anecdotally, certain surgeons have just buttressed it and fixed the proximal fragment, and they haven't put any screws onto the distal fragment as well, given the buttress configuration. So that is also has been practiced by certain surgeons, but there is no literature evidence for that. Coming to this good article to read about this dorsal Barton fracture, and it is a variation of the dorsal radiocarpal dislocation. In these pictures, it is nicely explained. On the left, in the dorsal shear injury, the volar ligaments are injured, whereas in volar shear injuries, the dorsal ligaments are injured. Mind you, in dorsal Barton fractures or volar Barton fractures, the ligaments are more or less intact. Coming to this case description, which we saw earlier, this gentleman around 18 years old age, he had this subtle volar shear fracture, which was very innocuous on the AP view, but on a lateral view, you need to watch closely, and this volar lip was getting sheared. Clinical picture shows the pronator quadratus is intact, but it is sheared off along with the articular surface. Now, these are the CM images after the fixation. We could get in the reduction well and fix up this fragment. I've added 2 screws into the radial styloid to give an additional buttress to the radial styloid. Now, in the long run, he went on to heal. Although there is a subtle articular step which is seen onto the volar lip fragment, but it settled down very nicely at this 6 months post surgery image. And subsequently, he went on to heal well with a good function at 3 years, and he has started doing gymnastics, which he likes. In a example of case 2, the homemaker lady, right-handed, Parkinson's and hemifacial spasm, all other medical comorbidities, volar shear again, and this was the case recording which we had. Standard volar approach, trans FCR exposure, pronator quadratus, which is seen the volar rim, and the watershed line, which is seen here. L-shaped flap of the pronator quadratus raised here. Very sorry. And this is the fracture surface which is seen over here. Just So just notice we have kept a lower folded sheet below the wrist to hyperextend, and this fragment was getting reduced nicely. And subsequently, we stabilized with a buttress configuration of the plate. Now, this particular design, these standard variable angle locking plates, the narrow, standard, and broad. This is seen on the picture here. We use the standard plate considering the width of the bone. That's a CT scan image. Provisionally stabilized with the K-wire. The plate was buttressing it well with a hyperextension of the wrist simultaneously. Stabilized with the cortical screw. Subsequently, we reduced it. We stabilized with the distal locking screws. And these are the X-rays what we took. Just yep. That's a good reduction, and the screws are subchondral in a 22-degree lateral view. Mind you, on a picture-in-picture format, you see the wrist is elevated by around 20 degrees. The elbow is resting on the desk, on the table. Subsequently, we have got the X-rays to see whether the distal locking screws are not penetrating the cortex over there. Yeah, this is kind of the Hoya view or a horizon view. And subsequently the pronator quadratus closure. And I could cover the implant well with the pronator quadratus closure. This is immediate post-op and 6-month post-operative. She went on to heal well with good function she has, and with good medical backup and the stabilization, she's back in active function now. Subsequently, the case 3 is roughly similar. This young lad had, just before the board exams 2 months back, he had severe injury while doing regular workout. These are the CT scan images wherein you can see the shear force onto the volar rim, and the complete volar rim was injured. Stabilized with the volar plate. He went on to heal well, and this is the picture at 6 weeks and already getting full range of motion. Case 4. Now this particular case is an interesting one. This is a bank manager, right hand, and he had injury during the sports activity. But herein he had significant dorsal rim fragment. Now, why this case was highlighted is basically since the volar cortex was injured, I decided to approach it through the volar approach, and I could get purchase onto this dorsal rim fragment very well. The picture on the left is somewhere around 3 months down the line, and picture at around 9 months or so, the dorsal rim fragment is nicely settled and he has went on to heal. Although he is under rehab and he is getting his full range given the complex or the severe soft tissue injuries he had, he doesn't have any block per se, but he has went on to heal well. And the last case, which I would like to show here is a similar volar shear pattern, but she had a depression in an intra-articular step. So analogous to the tibial plateau fractures, what we did, you can see the Siam image, there is a subtle intra-articular step, which we tried to elevate it to the mosquito forceps. We slightly overcorrected it and got the articular element, and the distal locking screws, we put it in a raft configuration to get the articular congruity well. And these are the Siam images here. And we have got the good articular surface restored. So in a nutshell, to understand this fracture geometry well, CT scan is very important to understand the fracture complexity, and shear force injuries need to be differentiated from fracture dislocation, for which the CT scan will help you. I thank you for your patient listening, and we welcome you for this annual hand surgery meeting, Asia Pacific Wrist Association and hand therapist, scheduled in September 2025 at Westin Powai. Thank you.
Doctor.